Hey, welcome back. If you're here for the first time, glad you found this. And if you've been following along, you already know this channel is about cutting through the noise, getting past the headlines, and actually understanding what the science says about your health. Today we're going to talk about something that affects almost every single person watching this video. We're talking about cholesterol and heart disease. Now, I know what you might be thinking. Cholesterol? I've heard this 1,000 times. And honestly, that's exactly the problem. Because most of what you've heard, and most of what your doctor may have told you, is based on science from the 1950s. 1950s. We are treating a modern metabolic crisis with a framework that was developed before the moon landing, before color television, before the internet. And the consequences of that gap between what we know and what we practice, those consequences are measured in lives. Here's the stat that really stopped me in my tracks, and that I think should stop you too. A landmark study looked at 136,000 heart attack patients admitted to hospitals across the United States. Researchers went back and looked at their labs, and what they found was shocking. 75% of those patients, 3 out of every 4 people who had a heart attack, had LDL cholesterol levels that were completely normal by our standard guidelines. Let that sit for a moment. 3 out of 4 people who showed up to the emergency room with a heart attack had normal cholesterol. They were following the rules, their numbers looked fine, and they still had a heart attack. So either our rules are wrong, or we're measuring the wrong things. And the answer, it turns out, is both. Today, I want to walk you through 5 major paradigm shifts. 5 things the latest science is telling us about cholesterol and heart disease that most people, and frankly most clinicians, don't know yet. By the end of this conversation, you're going to have a completely different lens through which to see your own health. And more importantly, you're going to know exactly what to ask your doctor at your next appointment. All right, so the first big shift, and this is the foundation. Everything else we talk about today builds on this, so I want to make sure this really clicks. When you go to your doctor and get a standard lipid panel, your routine cholesterol blood test, what does your doctor measure? They measure your total cholesterol. They measure your LDL, which we call the bad cholesterol. They measure your HDL, the good cholesterol, and they measure your triglycerides. Now here's the problem. When your doctor looks at your LDL number, let's say it comes back at 120 milligrams per deciliter. What they are measuring is the total weight, the total mass of all your LDL cholesterol floating in your blood. Just the weight. And I want you to think about this analogy, because I think it perfectly captures why that's a problem. Imagine you're a city planner, and you want to know how congested the highway is. Someone gives you a report that says, there are 50,000 pounds of cargo moving on the highway right now. Okay, is that a lot? Is that a little? Is traffic bad? You have no idea, because 50,000 pounds of cargo could be one giant semi-truck, or it could be 500 small cars. And those two situations create completely different levels of congestion, completely different risks of accidents. That's exactly the situation with LDL cholesterol. The weight doesn't tell you how many particles are carrying that cholesterol. And it's the number of particles and the size of those particles that actually determines your risk. Here's what the science tells us. There are essentially 2 types of LDL particles. The first type is large, buoyant, fluffy particles. I like to think of these as beach balls. They're big, they're light, they're round. They float around your bloodstream, and when they bump into the wall of your arteries, they just kind of bounce off. They don't cause much damage. Your body deals with them fine. The second type, small, dense LDL particles. These are more like BBs, like the little metal pellets from an air gun. They're small, they're hard, they're dense. And instead of bouncing off your arterial walls when they collide, they penetrate. They wedge themselves into a lining of your arteries. And that is where arterial plaque begins to form. That is where the disease starts. Now here's the critical question. Can your standard LDL number tell you which type you have? The beach balls or the BBs? No, absolutely not. Your LDL number tells you nothing about particle size or particle number. You could have an LDL of 140 made up almost entirely of big fluffy beach balls and have a relatively low risk. Or you could have an LDL of 100, which your doctor might call great, made up of thousands and thousands of small, dense BB particles. And your arterial walls are getting peppered right now, even as your doctor tells you your cholesterol looks good. In medicine, we call the dangerous pattern atherogenic dyslipidemia. It's a mouthful, but all it means is a pattern of blood fats that promotes plaque formation. And the hallmarks of this pattern are a high number of small, dense LDL particles, elevated triglycerides, and low HDL. It's a specific metabolic fingerprint, and it's almost invisible on a standard lipid panel. Here's what makes this even more frustrating from a clinical standpoint. We have the tests to measure this. We have ways to look at particle number and particle size. There's a test called an NMR lipoprofile. There's a marker called apolipoprotein B, ApoB, which I'll come back to in detail at the end of this conversation. These tests exist, they are available, they are not outrageously expensive, and yet fewer than 1% of physicians in the United States routinely order them. Less than 1%. So the system is set up to look at cargo weight. And meanwhile, the number of trucks on the road is running rampant, and we just aren't looking. That's the first crack in the foundation of everything you thought you knew about cholesterol. And it leads us directly into the second, which is arguably even more important. Okay, so we've established that the type of LDL particle matters more than the amount. But now, I want to zoom out even further and ask a bigger question. Why does LDL become a problem in the first place? Because here's the thing, cholesterol is not inherently bad. I cannot stress this enough. Cholesterol is not the enemy. Cholesterol is a molecule your body absolutely cannot live without. Your brain is 60% fat and cholesterol. Every single one of your cell membranes is built with cholesterol. Your body uses cholesterol to make hormones, testosterone, estrogen, cortisol. It uses cholesterol to make vitamin D. It uses cholesterol to make bile, which you need to digest fat. Cholesterol is so essential that your liver manufactures it constantly, regardless of how much you eat in your diet. If you eat less cholesterol, your liver makes more to compensate. Your body fights to maintain cholesterol because it needs it to survive. So, the question isn't, how do we get rid of cholesterol? The question is, what makes cholesterol go from a necessary molecule to a dangerous one? And the answer is oxidation. Let me give you an analogy that I think really makes this clear. Think about a bottle of olive oil sitting on your counter. Fresh olive oil is healthy, full of beneficial compounds, good for you. Now leave that olive oil out in the sun for a few weeks. It goes rancid. It oxidizes. Those same molecules that were beneficial are now producing harmful byproducts. The oil hasn't changed in terms of its basic chemistry. It's still fat. But its interaction with oxygen has turned it into something damaging. The same exact process happens to LDL cholesterol in your bloodstream. When the environment inside your body is chronically inflamed, LDL particles get exposed to reactive oxygen species, essentially free radicals, and they become oxidized. We call this oxidized LDL, or ox-LDL. And oxidized LDL is absolutely toxic to your arterial walls. Your immune system sees it as a foreign invader. It sends in macrophages, your immune cells, to gobble up the oxidized LDL. Those macrophages get so engorged that they become what we call foam cells. Foam cells accumulate in the arterial wall. They form fatty streaks, and over time, those fatty streaks become plaques, and plaques rupture and cause heart attacks and strokes. So, The chain of events goes chronic inflammation, oxidized LDL, foam cells, plaque, heart attack. Cholesterol is in that chain, yes, but it's not the cause. It's the victim. Inflammation is the initiating force. Inflammation is the spark that starts the fire. And this is why the old model, lower your cholesterol, lower your risk, is so dangerously incomplete. Because you can have a very high cholesterol level with very low inflammation, and your LDL particles will largely stay unoxidized and relatively harmless. Research from Harvard has demonstrated this. If your cholesterol is high but your inflammatory markers are low, your cardiovascular risk is much more modest than we previously thought. But flip that scenario. If your inflammation is chronically elevated, even if your cholesterol level is completely normal, even if your LDL looks perfect on paper, those LDL particles are sitting in an oxidative, inflammatory environment. And they are getting deposited into your arterial walls. Your perfect labs are giving you a false sense of security. This is why I often say, heart disease is not a statin deficiency. Statins work, in part, because they have anti-inflammatory properties, not just because they lower cholesterol. The cholesterol-lowering effect of statins may actually be somewhat incidental to some of their cardiovascular benefit. The real question we should be asking every patient isn't just, what is your LDL? It's, what is the level of inflammation in your body? And we have a marker for that. It's called high-sensitivity C-reactive protein, or hsCRP. It's a protein your liver produces in response to systemic inflammation, and it is one of the most powerful predictors of cardiovascular events we have, arguably more powerful than LDL. But how often do you see hsCRP on a standard lab panel? Rarely, almost never. We're measuring the smoke while the house burns down, and that brings us to the third big revelation, and honestly, the one that is going to be the most controversial and the most important. For my entire medical training, and for most of the past half-century, the dietary advice around heart disease was built on one central pillar: fat, specifically saturated fat, is bad for your heart. Eat less fat, eat less butter, eat less red meat, eat less eggs, swap your whole milk for skim milk, replace your butter with margarine. That was the message. Millions of people followed it. The entire food industry restructured itself around it. Low fat became synonymous with healthy. And so we got low-fat cookies, low-fat yogurt, low-fat everything, all with the added sugar that manufacturers threw in to make food palatable after they stripped out the fat. And here we are, 50 years later, fatter and sicker than ever before, with heart disease still the #1 killer. Something went very wrong, and increasingly, the data is pointing at the same culprit. We blamed fat, but the real villain was sugar. Now, before we go further, let me give credit where credit is due. This shift has been difficult for the medical community because the original research linking saturated fat to heart disease wasn't fraudulent by intention. It was genuinely believed to be correct based on the data available at the time. But subsequent, much larger analyses have complicated the picture enormously. Massive meta-analyses, studies that pool data from hundreds of thousands of patients across multiple decades, have repeatedly found that for the general population, dietary saturated fat has a largely neutral relationship with cardiovascular events. Not protective, not catastrophic. Neutral. Meanwhile, the evidence against refined carbohydrates and added sugar has been building for decades, and it's now overwhelming. Let me walk you through the mechanism, because once you understand how sugar damages your heart, you will never look at a slice of cake the same way. When you eat refined carbohydrates, white bread, white rice, pasta, sugary drinks, pastries, cereal, they are rapidly digested and absorbed as glucose. Your blood sugar spikes. Your pancreas responds by pumping out insulin to shuttle that glucose into your cells. If this happens occasionally, your cells respond normally. But if you are eating a high-sugar, high-refined carbohydrate diet day after day, year after year, which is the standard American diet, something breaks down. Your cells, especially your muscle cells, start to become desensitized to insulin signal. They stop responding appropriately. We call this insulin resistance. Now, insulin resistance is the root of almost every metabolic problem we face. And here's specifically what it does to your cardiovascular system. When your body is insulin resistant, your liver starts doing something it shouldn't. It converts excess glucose and fructose into fat. This process, called de novo lipogenesis, produces triglycerides. Those triglycerides flood into your bloodstream. Your triglyceride levels go up. At the same time, your HDL, your good cholesterol, goes down. And critically, the composition of your LDL changes. Your big, fluffy beach ball LDL particles get converted into those small, dense, dangerous BB particles. You remember, the ones that penetrate your arterial walls. So high sugar intake drives insulin resistance, which drives high triglycerides, which drives low HDL, which drives small, dense LDL. This is the exact metabolic fingerprint of atherogenic dyslipidemia that we talked about earlier. This is the pattern that causes heart attacks, and it is created not by butter or eggs, but by chronic excess sugar and refined carbohydrate consumption. And then, because insulin resistance also promotes systemic inflammation, those BB particles are floating around in an oxidative environment where they get rusty and get deposited into your arterial walls. You now have every ingredient needed for a cardiovascular catastrophe, all from too much sugar. The other thing that insulin resistance does, and this is important, is it promotes what I call angry fat. The fat that accumulates not under your skin, but deep inside your abdomen, around your organs, your liver, your kidneys, your intestines. This fat is metabolically active in a way that subcutaneous fat, the fat under your skin, is not. Visceral fat functions almost like a rogue endocrine organ. It secretes inflammatory cytokines. It produces hormones that promote insulin resistance. It releases free fatty acids that further damage your liver, and it cranks up systemic inflammation throughout your entire body. This is why the shape of your body, specifically the ratio of your waist to your hips, is often a better predictor of cardiovascular risk than your body weight. Two people can weigh exactly the same, but if one carries their fat viscerally and the other carries it subcutaneously, their cardiovascular risk profiles are completely different. So when we talk about heart disease being driven by sugar, we're not just talking about the direct biochemical effects of glucose and fructose. We're talking about the entire metabolic cascade that chronic sugar overconsumption sets in motion. And it's a cascade that runs directly into the wall of your arteries. Now I want to talk about something that doesn't get nearly enough attention, because it challenges a deeply held assumption that you can tell who is metabolically healthy just by looking at them. We tend to think of metabolic disease, insulin resistance, prediabetes, cardiovascular risk as a problem for people who are overweight or obese. The cultural image of someone with heart disease risk is someone who is visibly large, eats fast food constantly, doesn't exercise. And while lifestyle factors certainly play a role, the reality of who is metabolically unhealthy in America is far more disturbing and far more widespread than that image. Let me give you a number that I think is one of the most alarming statistics in all of modern medicine. Research out of Tufts University analyzed data across thousands of Americans using 5 standard metabolic health markers: blood pressure, blood sugar, triglycerides, HDL cholesterol, and waist circumference. They used the conventional definition of metabolic health, meaning these markers are all in the healthy range without the use of medication. The result? Only 6.8% of Americans, fewer than 7 in 100 people, qualified as fully metabolically healthy. Think about that. 93.2% of the American population has at least one metabolic abnormality. More than 9 out of 10 people are metabolically compromised to some degree, and most of them have no idea. And here's where it gets particularly tricky. Roughly 20% of people who are in the so-called normal weight range, people who by BMI standards are not overweight or obese, are what we now call TOFI. Thin on the outside, fat on the inside. They look fine. They step on the scale, and the number looks reasonable. Their BMI comes back normal. Their doctor says, "You look healthy. Your weight is fine." But inside, their body composition tells a completely different story. They have more body fat relative to muscle than is healthy. They carry significant visceral fat deposits around their organs, even though their overall weight is normal. And they have insulin resistance, sometimes severe insulin resistance, that is silently driving inflammation and small dense LDL production and progressive arterial damage. This is the skinny fat epidemic, and it is one of the primary reasons why 3 out of 4 heart attack patients have normal cholesterol, because the standard workup isn't designed to catch these people. Their weight is fine, their cholesterol is fine, their basic labs are normal, and then one day they have a cardiac event that comes as a total shock. So how do you know if you might be in this category? There are some simple starting points. First, the tape measure. Your waist circumference matters more than your weight. In general, a waist circumference above 35 inches for women and above 40 inches for men is associated with significant metabolic risk. But even below those thresholds, your waist-to-hip ratio is informative. You want your waist to be smaller than your hips. A waist-to-hip ratio above 0.85 for women or above 0.90 for men is a warning sign. Second, think about where your fat sits. Do you carry your weight centrally, around your abdomen and belly, or peripherally, around your hips and thighs? Central adiposity, the apple shape, is the dangerous pattern. Peripheral fat, the pear shape, is relatively less concerning. Third, and I'll get into the specific labs in detail in a moment, a few simple blood tests can tell you a tremendous amount about your metabolic status. And I'm not talking about the tests that are automatically run on your standard panel. I'm talking about the tests you have to specifically request. But before we get there, let me also outline what metabolic dysfunction looks like as a clinical picture, because it often presents not as one dramatic problem, but as a cluster of seemingly unrelated issues. High blood pressure, triglycerides trending upward, HDL trending downward, fasting blood sugar creeping toward the pre-diabetic range, a little more belly fat than a few years ago, energy fluctuations throughout the day, especially that afternoon crash after lunch, brain fog, difficulty losing weight despite calorie restriction, disrupted sleep. These things seem unrelated, but they are all downstream manifestations of the same root cause: metabolic dysfunction and insulin resistance. And here is the most hopeful and most important thing I can tell you about all of this. Metabolic dysfunction is reversible. Unlike many diseases, insulin resistance responds dramatically to lifestyle intervention. The biology can be changed, the trajectory can be reversed, but you have to know it's happening first, which brings us to the final section and the most actionable one. Everything we've talked about so far, particle size, inflammation, sugar's role, metabolic dysfunction, it all points to the same conclusion. We need to be measuring the right things. The standard lipid panel was designed in an era when our understanding of cardiovascular disease was primitive by today's standards. It gives you a partial picture, a blurry photograph. And we've been using that blurry photograph to make life or death treatment decisions. So let me tell you what I believe every person should know about their cardiovascular health. Not just the basics, but the complete picture. Let's start with imaging, because I think this is underused and underappreciated. Labs tell you about risk. They tell you about what might be happening, but imaging can actually look at the disease process itself. The most accessible and widely available test is the coronary artery calcium score, often just called a CAC score or calcium score. It's essentially a very low-dose CT scan of your chest that looks for calcified plaque in the walls of your coronary arteries. It is fast, it is relatively inexpensive, and it gives you direct evidence of whether atherosclerosis, the actual plaque disease, is present in your arteries. A CAC score of 0, meaning no detectable calcium, is actually extremely reassuring. Research suggests that a 0 score in someone who is not at very high genetic risk is associated with very low short-term cardiovascular event rates, even if some traditional risk factors are present. On the other hand, if your score comes back elevated, you now have concrete evidence that the disease process is already underway, and that is a very different clinical situation that warrants aggressive intervention. This is critically important for making informed decisions about long-term medication use. If you are being recommended a lifelong daily medication, don't you want to know whether the disease you're trying to prevent is actually already there, or whether you are treating a number on paper that may or may not represent real risk? Get the imaging. Look at the plaque. Now, let's talk blood work. Here are the 5 markers that I believe should be standard of care and that are currently ordered by a small minority of clinicians. Number 1. Apolipoprotein B, or ApoB. This is the single best blood test for cardiovascular risk that most people have never heard of. Every single LDL particle, every VLDL particle, every IDL particle, every atherogenic particle in your bloodstream has exactly one ApoB molecule on its surface. So when you measure ApoB, you are directly counting the total number of all harmful particles in your blood simultaneously. No estimation, no calculation, just a direct particle count. This is so much more powerful than LDL-C, the standard LDL cholesterol weight measurement, because it directly captures what we care about, the number of particles that can penetrate your arterial wall. And as of 2023 and 2024, major cardiology guidelines now officially recognize ApoB as a causal factor in cardiovascular disease. This isn't fringe science anymore. This is mainstream cardiology. Ask your doctor about it. If they look at you blankly, you now know more than you might expect. Number 2. Lipoprotein A, or LPA. This one is genetically determined. You cannot change it much with lifestyle or diet. And approximately 1 in 5 people, 20% of the population, has an elevated LPA. It is an independent and powerful driver of heart attacks and strokes, operating through mechanisms that are separate from regular LDL. Someone can have perfectly normal LDL, perfectly controlled blood pressure, a healthy lifestyle, and still be at significantly elevated cardiovascular risk because of their LPA. You only need to check it once in your life. It doesn't fluctuate like other markers, but it's crucial to know if you are in that 20%, because it dramatically changes how aggressively you need to manage all your other risk factors. You need to know this number. Number 3, high-sensitivity C-reactive protein, or hsCRP. We talked about this earlier. This is your inflammation marker, your fire alarm. CRP is produced by your liver in response to systemic inflammation, and elevated hsCRP is one of the strongest independent predictors of cardiovascular events we have. Ideally, you want your hsCRP below 1.0 milligrams per liter. Between 1 and 3 is intermediate risk. Above 3 puts you in a high-risk category, regardless of what your cholesterol looks like. Knowing your hsCRP tells you whether the inflammatory environment is present that would make your LDL particles dangerous, because without that oxidative, inflammatory environment, even elevated LDL is far less threatening. Number 4, fasting insulin. This is, in my view, the most underutilized longevity test in medicine. Not fasting blood sugar, fasting insulin. Here is why this matters so much. When insulin resistance is developing, when your cells are beginning to ignore insulin's signal, your pancreas compensates by producing more insulin to force the same effect. Your blood sugar stays normal because your pancreas is working overtime, but your insulin level is silently elevated. For years, sometimes for a decade or more, your blood sugar can look completely normal while your fasting insulin is elevated, quietly telling you that you are developing insulin resistance. By the time your blood sugar rises into the pre-diabetic range, the underlying metabolic dysfunction has often been present for many years. Fasting insulin catches this early. Ideally, you want a fasting insulin below 5 to 6 micro-IU per milliliter. If yours is above 10, you have meaningful insulin resistance, regardless of what your blood sugar says. If it's above 15, you have significant metabolic dysfunction that needs to be addressed now, not when your A1C eventually creeps up. This test is cheap, it is widely available, and it gives you a window into your metabolic health that virtually no other standard test provides. I cannot overstate how important this one is. Number 5. Triglyceride to HDL ratio. This is your quick metabolic check, the one you can calculate yourself from your standard lipid panel right now. Take your triglyceride number and divide it by your HDL number. That ratio tells you an enormous amount. Ideally, you want a ratio close to 1:1. Triglycerides roughly equal to HDL. If your triglycerides are 80 and your HDL is 70, you're in great shape metabolically. If your triglycerides are 150 and your HDL is 30, your ratio is 5:1, and that is a metabolic disaster. That pattern is almost synonymous with significant insulin resistance and a high burden of small, dense LDL particles. Even if your total cholesterol and your standard LDL look perfectly normal. So, ApoB, LPA, HSCRP, fasting insulin, triglyceride to HDL ratio. Write these down. Screenshot this. These are the 5 conversations you should be having with your healthcare provider.
Don't forget to hit that subscribe button and join the journey.
All right, let me bring all of this together because I want you to leave this conversation with a clear message. Heart disease is not a simple cholesterol problem. It is a metabolic disease. It is an inflammatory disease. It is driven by decades of elevated insulin, visceral fat accumulation, oxidative stress, and chronic low-grade inflammation, all of which are in large part the result of a food environment saturated with refined carbohydrates and added sugar. The standard approach: measure total cholesterol, prescribe a statin if it's high, tell the patient to eat less fat, is not wrong in every case. Statins do help certain high-risk populations. Lowering LDL does reduce events in people with established heart disease. I'm not here to tell you to stop your medication and don't eat bacon for every meal. But I am telling you that the framework is too narrow. It is missing most of the picture. And for the millions of people who are doing everything right by conventional standards, taking their statin, keeping their LDL in the normal range, watching their fat intake, and still having heart attacks, that framework is failing them. You deserve a complete picture of your cardiovascular health. You deserve to know your ApoB. You deserve to know your LPA. You deserve to know your HSCRP and your fasting insulin and your triglyceride to HDL ratio. You deserve to know whether there is actual plaque in your arteries or whether your risk is theoretical. You deserve to make decisions based on your real biology, not on a 1950s approximation of it. And more than anything, I want you to understand this. The most powerful cardiovascular medicines we have are not in the pharmacy. They are in your kitchen. They are in the way you move your body. They are in the quality of your sleep. The anti-inflammatory, whole foods diet that eliminates refined carbohydrates and added sugars, that addresses the root cause. Exercise that builds muscle and improves insulin sensitivity, that addresses the root cause. Sleep that regulates cortisol and insulin and inflammation, that addresses the root cause. You have more control over this than you have ever been told. The biology is not fixed, the trajectory is not inevitable, but you have to have the right information to act on. So take this conversation. Take these 5 tests. Have a real discussion with your doctor, an informed discussion, a specific discussion, the kind of discussion that comes from knowing what questions to ask, because your heart has been working for you every single day of your life. It's time to return the favor. Thanks for being here. If this was useful, share it with someone you care about, because this is information that genuinely saves lives. See you next time.